Good afternoon. I'm Harvey White from Auckland, New Zealand, and I'm delighted to co-chair this with Christian Tigerson from Aarhus, Denmark. The title of the session is Understanding the Universal Definition of Acute Myocardial Infarction. There's no question mark after that. And we have a group of speakers, some of them who are on the Universal Definition Consensus group, and my co-chairman is co-chairman of the group. So it's a great delight to ask our first speaker, Alan Jaffe from Rochester, Minnesota. And the title of his talk is Distinguishing AMI from Cardiac Injury Due to Other Causes. We will have questions directly after the speaker's presentation, if they keep the time, and then we'll try and have a panel at the end. Thank you, Alan.
Thank you, Harvey. By way of framing this conversation, I think we acknowledged, and it's been clear for a long time, that there are lots of elevations of cardiac troponin, and they're all indicative of some sort of cardiac injury, but they certainly are not all commensurate with acute myocardial infarction. And the question is, how do you distinguish between those that are and those that are not? And there are really two ways. One is to use troponin to distinguish acute from chronic elevations, and the second is to try and distinguish one acute etiology from another. Just in regard to background, in terms of what the frequency of these elevations are, these data come from the Dallas surveillance study with a standard non-high sensitivity troponin T assay. And in their general population, they found that a little less than 1% of the community had a value that was elevated using this assay, which is a relatively insensitive one. And that invariably, elevations were associated with comorbidities, whether 1, 2, 3, or 4, and the comorbidities here were left ventricular hypertrophy, renal failure, heart failure, and diabetes. So you can see if you have all of those, you have a fairly substantial incidence of having an elevated troponin at baseline. And if it's little less than 1% in the community, maybe it's 5% in the emergency room, and maybe that makes it 10% in the hospital. If one looks at higher sensitivity assays, these data come from the exact same data set, but utilizing the high sensitivity assay, it goes to 2% in the overall population, shown here in this. And maybe that means 15% in the emergency room and 30% in the hospital. So there are going to be real tensions. If one looks in particularly with high sensitivity assays, it's clear whether one believes this is due to comorbidity or normal aging, that as we get older, values will go up. And in our own experience, when we try and correct for these, we find that one needs to use imaging to detect really subtle abnormalities, like the ones here, all of which influence those values. Whether it's due to a comorbidity or not, clinicians are going to have to deal with that. And the paradigm for dealing with it really originally came from the renal failure population. These data are published in Circulation from Fred Apple originally, showed that if you had even a modest elevation of troponin T, you can see that your mortality at 2.5 years was about 50%. So these are wildly prognostic and very important, but they're not necessarily commensurate with myocardial infarction. And they are associated, just to touch this base, with evidence pathologically of myocardial injury. So they're not false positives. If one looks then when patients present with acute coronary syndromes, their values go up. And this provided the substrate for thinking that patients who had elevated troponins at baseline due to chronic structural heart disease most often, when they came in, should have a rising or falling pattern of values. With conventional assays, this is fairly easy to do. For those of us, and I have a little bit of a laboratory background, You get a precision plot like this of the assays. You then, for those of you who like formulas, you take the standard deviations around the formulas, and the formula is roughly there as shown in the bottom. So it's roughly 3 standard deviations of the variation around the values, which for an assay that's at 5 to 7% is a 20% change, which means once elevations occur and one has that sort of variability out here, that you're safe using a 20% change. But when you're down here and the variability is much higher, you need to use higher values. And for that reason, rather than allowing clinicians to struggle with this, we at the Mayo Clinic simply report it as part of our results section. And the Global Task Force has recommended that laboratories be responsible for doing this because, as you can imagine, this can get a little bit difficult for the average clinician to do. This has turned out to be a good innovation, but you have to be careful, because if you're there and there, or in particularly if this arrow were over here, you can see you could have very high values and you could say, well, they're not changing. That's a clinical distinction. If you're here and here because you're late, you also could misappropriate and misdeal with the values, so that you need to keep your clinical thinking hat on. With higher sensitivity assays, this gets to be a little bit more complicated, and we can generate a little better information, because we can measure biologic variability by measuring repetitively samples and ask the question, how much biologic variation should we add? And we can then use that same formula, roughly a 3-fold increase, and generate something called the reference change value, which you see here is in the range of 50 to 60% in most studies. Now, this may be too much in some clinical circumstances, and I'll actually argue that it is sometimes too much. But if indeed you're beyond it, you know at least with a high degree of certainty that those values are not occurring due to biologic and analytic variation alone. Over time, with high sensitivity, a variety of approaches have been utilized to operationalize the change in values. This is one that comes from one of our chairmen, Harvey White, who suggested for the high sensitivity troponin T assay a 50% change if the value was relatively low, and recognizing what I told you, which was the value was higher, the concern is that when values get quite high, very high percentages may not be nearly as sensitive as they need to be, suggested a 20% change. There are a variety of other data that have taken issue with the idea of using relative percentages and have suggested that absolute changes provide a better separation. And if one looks at those data, and there are several, this is one study and here is a second, the majority of those studies would suggest that near the 99th percentile, these change criteria are similar, whether they're absolute or relative, but at higher values is where it appears that the absolute values may have more benefit. Now, one of the key issues in looking at this, and I think it's important when we show you data that we're careful about the quality of it, is the gold standard that is used to generate it. And if you use a high gold standard to define myocardial infarction, or assay values that are high, you have bigger infarctions and you change the delta. So here's the delta if you use the 10% CV of the troponin T assay. Here's what happens if you use the 99th percentile. Here's what happens if you add the 25 infarctions in this particular study called TUSCA that were detected with the high sensitivity assay. And this has confounded the literature and continues to confound the literature. To some extent, it's an understandable problem because there's a circular logic if you use the high sensitivity assay as its old gold standard in terms of how you classify these patients. But it is a tension when you see these data that you need to look at and be aware of. Now, I would argue against this sort of approach, which suggests that you can do this in an hour or 2 hours, utilizing absolute or relative changes, because in particularly at low values, the assays are not sufficiently precise to make the distinction. But in addition, it makes an assumption that I think may be right in some patients, but may often be incorrect, which is that somehow release is continuous because coronary blood flow, which is what causes the marker to get to the circulation, is a continuum. And I think in many patients, as we all know, that's not the case. If one looks, however, and takes the criteria, whether they're the relative criteria or the absolute criteria, it is very clear that in some subsets of patients, here are a subset, some of which you could argue might have acute disease, like heart failure, some of which shouldn't, that there will be some overlap with these criteria, no matter how good they are. And what it suggests is that there will be, for some patients, a tension, a middle ground between sensitivity and specificity, and I graphed these from a paper in JAMA utilizing the high sensitivity Abbott assay because it shows this quite clearly. So there's an element of this that's going to need and it's going to require clinical judgment. So my guidance, in order to do this right, you need to have fixed sampling times. Near the 99th percentile, I think, the greater the change, the more likely the MI, and the less likely. Percentage and absolute values look similar to me. At higher levels, absolute values may be better. And there may be the need for different rule out and rule in metrics. Time will tell. Avoid. You can't use the data from one assay for another. And the ID release is continuous, and you can use 1 or 2 hour deltas. By dividing the delta, find it 6 hours, I think, is not in keeping with good practice. A couple of additional caveats to doing this. If you have bad samples, you will end up having bad results. This is just one example. We at the Mayo Clinic draw about 80% of the samples from intensive care units from lines. It's a good way to get hemolysis. You need to be terribly careful. It lowers troponin T values. For many assays, it raises troponin I values. But there are also going to be other acute etiologies that are going to cause a rising pattern of troponin. Here's one example. It turns out to be a woman who had normal coronary arteries but had chest pain. And it's important to understand that some women, and particularly with more sensitive assays, we're detecting more and more of them, can have these events. Some people would say they're due to endothelial dysfunction. These are data utilizing IVUS that suggest that even when the coronaries look normal, you can sometimes see plaque rupture events. And obviously, spontaneous coronary artery dissection can occur and does occur. So some of these elevations you shouldn't automatically say just because they're normal coronary arteries or putatively normal coronary arteries couldn't be due to infarction. There are many other elevations that can occur, and I'm not going to touch all of them, but I did want to call your attention. Heart failure. The more highly sensitive the assay, the more frequent the elevations will be. They'll be prognostic. We'll learn how to use them, but this will be a circumstance where one will have to use clinical judgment in determining which subset of these patients might have a myocardial infarction. Here's another list, long list, but some examples. Carbon monoxide poisoning. they may have a rising pattern of values. Acute atrial fibrillation, they will have a rising pattern often, but I would point out to you, and I think it's just important to understand, and I'll go through this quickly, that these values are highly prognostic for a baseline. They're much better, and they augment the CHADS-2 VASC score for both embolism, mortality, and bleeding. So these are going to be valuable, but they may give you a rising pattern, as will the critically ill patients. And this is the first study done with a prototype assay in 1995. And what you can see is that if you're terribly ill and your troponin is elevated, regardless of whether it's recognized or not, your mortality is much, much higher. And in the acute setting, we still have a lot of work to do to figure out what to do about that. But one reason to call your attention to this is that even when these patients go home, they have a markedly increased mortality. And we ought to at least be looking at those individuals to try and say, is there a sensible, easy prophylactic regimen to put them on? So back to my last and first slide. It's terribly important to try and distinguish based on the troponin pattern and then on clinical care which of these elevations are due to myocardial infarction and which are due to cardiac injury. There will be a talk later in this session by Dr. Morrow to try and help you distinguish type 1 from type 2 myocardial infarction. Thank you very much.
Thank you very much, Alan. This paper is open for comment and questions. Come to the microphone and identify yourself. So you talked about change. Did you talk about, you touched on it, but what can we glean from the elevation? Can we glean that this is likely Takotsubo's, likely myocarditis, likely MI from the height of the rise?
Well, not the height of the rise so much, although I think it is fair to say that marked elevations of troponin with contemporary assays and or high sensitivity assays, if they're markedly elevated, the most common diagnoses are acute myocardial infarction or myocarditis. Myocarditis can have a wide range of elevations from very, very modest to very, very elevated, even more elevated than acute myocardial infarction. But by and large, those are the two that give you a really marked signal. There's some controversy in the literature as to how high the values go in apical ballooning. Our own experience at Mayo suggests they're quite modest, but there are some people who have reported much higher values.
Hi, Arnold Cito from UC Irvine. Dr. Jaffe, you have written that there is a demise, you've written about the demise of CKMB. And I think I just want to ask, is there no added value to using the CKMB as a secondary confirmatory test, as a less sensitive but potentially more specific marker for large MIs?
Well, if anything, I would argue it's less specific. I mean, if you look at the basic science, CKMB is found in skeletal muscle, kidney, prostate. In point of fact, there are very good data from the early troponin literature from multiple sources to suggest that when you have an elevated CKMB, which is maybe 10 to 12% of some cohorts, that there's no prognostic significance in the absence of an elevated troponin. So it has less specificity, not more specificity. So no, I don't think there is any real reason to use it anymore other unless that you're trying to spend additional monies.
Yeah, I can do. So you showed differences with gender, Alan. Recommendations are that we should use gender cuts for CKMB. Nobody seems to do it. Should we do that with troponin?
I do believe that eventually we will come to the conclusion that with high sensitivity assays, we should. With with contemporary assays that are in use in the United States today, they really are not necessary and we can't see a distinction. With high sensitivity assays, there are mixed data. Some data David Morrow has published a paper in Clinical Chemistry on the first samples of patients from a large trial suggesting that there isn't very much difference. But Nick Mills from Edinburgh has published in particularly that women particularly benefit from lower cutoffs associated with that status. And it's been known for a long time that women elaborate less troponin than do men. So I do believe that it'll be helpful for women. It may not turn out that gender-specific cutoffs will help the diagnosis in men nearly as much.
Alan, you mentioned, oh, sorry.
I see you do troponin T. Is there an advantage to that over troponin I? I believe with the troponin I, if there are things like rheumatoid factor and all, it may give you a false positive.
The clinical sensitivity and specificity of the contemporary assays are relatively similar. At present, if one compares the assays in the United States, the fourth generation troponin T assay is less sensitive than many of the troponin I assays from the point of view of sensitivity. There are a few more analytic problems with some of the I assays. With high sensitivity, it appears that the cardiac troponin T assay will be a less high sensitive assay. Some people have even argued it may not be a high sensitivity assay than some of the other high sensitivity I assays. And there are going to be some confounds with both that are both analytic, and at least for troponin T, there is some question as to whether or not an occasional patient with skeletal muscle disease could have an elevation.
Alan, you mentioned that the troponins could be elevated in the elderly population, perhaps also in women. Is that because of comorbidity, or is that, how is the figures collected in that way? Because was that collected from a normal elderly population, or?
Well, it's one of the tensions in the field, Christian, and I think you and I in particular should avoid the word elderly. If one takes the way most companies do normal range studies, and most clinics and most laboratories, you fill out a form and you say you're normal and you'd like some money to have your blood drawn. And if you do the studies and you then say, well, maybe that's not good enough, and you add some additional biochemistry such as NT-proBNP or a creatinine and EGFR, the values come down. If you then add imaging and look for subtle comorbidities, the values come down still more. And so there is an argument to be made in our own data set, comes down to almost null when we use imaging. But there are other data sets that I'm aware of from good groups that, despite the use of imaging, still find a gradient in individuals who are slightly older, such as we are.
Okay. Well, thank you, Alan, very much. And then I think we will proceed.